Welcome back. Part 3. Look at the picture on the right. Is there something wrong with it? What's weird? Some of you might say, "Whoa, doc, hala, bakit yung end ng tube palabas sa bibig? Di ba dapat nandun siya sa esophagus pababa dun sa stomach? Then why is it that way? Are we doing this wrong?" Well, let me enlighten you through our step-by-step procedure in this video. After the patient is anesthetized and positioned on its right lateral recumbency, a cushion is placed below the neck for elevation and isolation of the esophagus against the skin. In this particular image, the esophagus cannot be seen yet. We expect it to be around this area. This structure is not the esophagus. Do not cut that area. That is, any guess? The external jugular vein. Now, the next important thing to do is to mark the area of the external jugular vein, as seen in this image. They're quite close. This structure is quite close to the esophagus, so it is better for you to mark the area that you need to avoid to prevent any unnecessary hemorrhage to happen. All right? The external jugular vein would automatically bulge on its own in cats upon neck extension. However, if it would not, you may put gentle pressure on the thoracic inlet, right here, around this area, I believe, to make it bulge and help you identify it. You may ask, Doc, those markers are not sterile. Are those pentel pen? But the site is sterile already. Why are we putting a non-sterile thing there? Well, the markers used in this case are what we call tissue markers. Tissue markers are manufactured and sold sterile for tissue marking during mass removals. Remember when we were discussing how to remove tumors? And you have to mark the healthy margins. You are going to cut on those areas. So you need sterile markers for that. That's what they used in this image. Once you are ready, insert your long forceps into the oral cavity and extend it into the cervical esophagus with the curved tips facing outward and dorsal to the jugular vein. Just put enough pressure on the forceps to press its tip against the skin. Make sure the forceps are long and thin enough to get through the boundary of the oropharynx and the esophagus, which is guarded by the hyoid apparatus. Using a scalpel blade, incise through the skin and subcutaneous tissue directly over the bulge made by the forceps tips. Make sure the clamps are closed and remain closed until the tips protrude out through the skin incision. The esophageal wall can be caught and torn if the box locks of the forceps are open and the tips separate before the tips penetrate the skin. So there is this concurrent pressure from the scalpel to incise over the forceps, and there is this pressure from the forceps handle to bring the tips up. Hopefully, that will be enough for you to bring the forceps tips out of the skin incision. Hold the handle rings firmly to prevent accidental unlocking and push the forceps out through the incision. As you can see, the tips are seen here, exiting the skin incision. I put emphasis on pushing the forceps because you don't want to make an incision which is bigger than the tube you are going to place. Now, once the forceps tips are out, open the tips. Now you can unlock the locks and open the tips just enough for you to grasp and clamp, again, grasp and clamp the distal end of the esophagostomy tube. After clamping the tube end, pull it gently out of the mouth. Now, the distal tube tip, this one here, that is held by the forceps, is now oriented rostrally, and the proximal end with the cap is oriented caudally. This is like the initial picture that you saw in our title page. So this is a necessary part of esophagostomy tube placement. This is also shown in this image. The tube has now entered the oral cavity out, and the proximal tip would be here. But doc, it's supposed to be going that way. Why is it going this way? Alright, I'll make this Tagalog so it's easier to follow. Kapag lumabas na yung distal tip, alright, this is where the holes are, okay? This should be in the esophagus. Once it's out here, okay, grasp it with the hemostatic forceps again, curve it back, and then gently push it back where it came from. Alright, so you want this part to go in again. To do that, to make it easier, while you're left, if you're right-handed, okay, your right hand should be supporting this end. Okay? Habang pinapasok nyo ito with your fingers or with your forceps with your non-dominant hand, your dominant hand would be pulling on this tip to make sure that this would go in. Once you pull this and you feel that this fold, okay, is on this area already, pull this cranially. That's one important thing to do. Hindi mo lang siya hihilahin. Hilahin mo siya pa punta dun sa ulo. Alright? This would reset the folding of the tube so that this distal tip would now be in this area and your proximal tip would be on this area. I'll show you a video to better visualize this. Once you have redirected or reoriented the tube so that the distal tip would now be on this side, this is the head, you can see there's teeth there, and this is the proximal end of the tube. Adjust it to your pre-measured length. As you can see, this is the marker right here, right? So that you know that at this point, right, the distal end would be in between or at the level of the 7th or 8th intercostal spaces. Let's watch a video on how it is done. To make sure you got it where it needs to be, a lateral radiograph can be taken. Most silicone esophagostomy tubes are radiopaque, so it will be seen in an X-ray. Count the ribs, and your tube must be in between the 7th and 8th ribs or intercostal spaces. Now, that tube will easily fall out if you do not secure it. That is where a Chinese finger trap suture pattern is done using a 0 to 2O non-absorbable suture material. A Chinese finger trap suture pattern starts with a simple bite on the skin adjacent to the entry incision as an anchoring suture. This is what we call an anchoring suture. The two strands of the suture is then brought onto the other side of the tube and secured with a surgeon's knot. It is brought, the ends are brought down again and are just crossed with each other, brought again to the top, knotted with secured with a surgeon's knot, and this is done alternately for 3 to 4 times. Another anchoring bite can be placed after the Chinese finger trap suture is done. Usually, if this is the last part, this could be anchored more on this skin to prevent any excessive traction to the first anchoring suture. Let's watch this video to see how it is done. As the first anchoring suture, that she's about to do. Alright. Over. With under, knot at the top, right. Flip it under, cross it, no knots at the bottom, just on top. Another anchoring suture can be placed to further secure your tube into the animal.